Welcome to Health Live at Seniors Today. It's the month of May and it's fairly hot because of the climate and because of the election season when if you are in, depending on which part of the country you may be in. Some of it may be causing headaches to all of us, right? And today we have a session by leading brain and spine neurosurgeon, Dr. Ishant Rege, on headaches demystified. But before I invite him to speak, I will introduce you to him. Dr. Ishant Rege is a consultant brain and spine surgeon with varied experience of managing operative and non-operative conditions of the brain and the spine. He has completed the postdoctoral fellowship in vascular and endovascular neurosurgery, which involves minimum invasive treatment of vascular disorders like stroke, stenosis, vein aneurysms, arteriovenous malformations, and arteriovenous fissulas, among others. After completing his MCH in neurosurgery as a university topper from the St. John's Medical College, Bengaluru, he secured a fellowship in vascular and endovascular neurosurgery at the Amrita Institute of Medical Sciences. It's interesting, we have a fair number of people here in these in our Health Life sessions from both Bengaluru as well as Kochi. With an experience of more than 3,000 routine and complex neurosurgical procedures, including a wide range of neurological conditions like brain tumors, traumatic brain injuries, stroke, vascular disorders, and spine care, his focus remains strongly on patient safety and outcomes. Welcome to Health Live at Seniors Today, Dr. Rege. How are you?
Thank you. Hello.
Hello.
Am I audible?
Yes, you are audible and very clear. This is the first time we've had neurologists and neurosurgeons in the past, but we are discussing a topic like headaches, perhaps for the first time. We've discussed strokes, we've discussed dementia, and various such various disorders, but headaches is something where it all starts, right?
Absolutely. So that was going to be the first line that I was going to say. This is a very common condition, a very important one, yet often neglected one. It is very much neglected, and it all starts with a headache. So it's very important to know what kind of headache it is so that we can go ahead, we can proceed with that and get the right treatment for it.
We have all senior citizens here, and some of us have kind of grown up on radio and television ads, Saradon Ke Saathi, and and all of those things about having the right medicines for headaches. But we'll get to it. First, I would invite you to make your presentation. Yes. As always, those of you who know how our format works, we will have Dr. Ishant Rege making a presentation on headaches demystified. Please watch it carefully, and after that, or even as he's speaking, you can ask your questions in the Q&A tab. Please mention your age and your gender. If you would like to ask a question anonymously, you can do that, or else you can mention your name, and we will ask the questions to Dr. Rege after he's made his presentation. Don't worry about taking notes, etc. While the presentation is on, we will be recording this presentation. It is being recorded as we speak, and we will be playing an edited video on Monday evening with the takeaways which are written by a medical practitioner. So you will get to see it once again. You will get to make notes later, at leisure. Over to you, Dr. Rege.
All right. Should I share my presentation?
We start, right?
Yeah. All right. Are my slides visible?
Yes. Yeah. Thanks. Go ahead, please.
Okay. So at the outset, I would like to thank Mr. Maheshwari for having me on this forum and giving me an opportunity to talk, like I said, about a very common but often neglected topic on headache. So I'd like to start right away. So, okay. So to begin with, what is headache? Okay, it's a very common thing. All of us have experienced it. Moreover, all of us are the reason that someone else is experiencing it at some point in time. So just to begin with, so headache is which consists of pain in the head and neck, which is arising from the pain-sensitive structures in the head. And it is a common disorder. It is one of the commonest disorders of the nervous system, and it ranks third in the overall neurological disease burden. It is after stroke and dementia that we see headache ranking third. Now, the concern is that only a minority of people with headache disorders are appropriately diagnosed and treated by a healthcare provider, which is the concern here. So just to have an overview of what are the pain sensitive structures, I won't be diving in deep into the anatomy of the brain, but just to have an overview so that we know why, what conditions and why they cause headaches. So if you see the brain matter as such, this brain or the brain parenchyma as such, interestingly, is insensitive to pain. So if you take something and you poke it into the brain, it's not going to be painful at all. Wherein lies the basis for doing awake surgery. Like you must have heard it or read it on the internet that a patient undergoing surgery, brain surgery, is playing the guitar or singing, where that is the basis for an awake surgery, that the brain per se or the brain as such is not pain sensitive, but the structures around it, commonly this protective layer, which we see the white layer around the brain is, which is known as the meninges, or these veins or arteries around it. And of course, the structures which are outside the scalp or the subcutaneous layers or muscles, all of these are the pain sensitive structures. So when I was discussing about awake surgery, just to complete that topic, so we give anesthesia up to till we reach the brain, that is till we do a small opening in the skull, and after that the patient is awake, which is very helpful when doing certain kind of surgery. It gives us valuable information. So the brain as such is pain insensitive, but structures around it are the ones which are pain sensitive. So headache being such a common topic, why would you or someone come to me or a doctor for further consultation? So who comes to a doctor is if it's an acute onset severe headache, or if it's an episodic or recurrent one, multiple episodes which are occurring over the last few days. It is not subsiding on over-the-counter medications. The episodes are recurrent. Or if it's a chronic headache, someone who is just tired of having medicines for a long time, finally decides after a few months that these episodes are recurrent, I should go and finally visit a doctor. So these are the conditions, or these are the situation where a patient would normally visit a doctor for a headache. All right, so as we know, a journey of 1,000 miles always starts with a single step. And in the journey for a headache, if we take the correct right initial step, then we won't have to travel those 1,000 miles. So headache, when someone has an headache, the first thing is to go to a pharmacy or just self-treatment with over-the-counter medication. So self-treatment is the first thing when someone has a headache. If it works, it's well and good. Everyone's happy. But sometimes, or maybe most of the times, it does not work. And then the patient would finally go to, or someone would visit a family physician who would then prescribe some stronger medicines and diagnose it. Hopefully, if it's correct, again, the pain subsides. But otherwise, if it does not, then that person is further sent to maybe an ophthalmologist or an ENT, suspecting that there is some visual problem of farsightedness or a nearsightedness which is not corrected, or maybe some amount of sinusitis, which is then further treated with antibiotics, which may be unnecessary. If it subsides, then if not, then again, patient goes further to a general physician, then suspecting it to be because of hypertension or an hypertensive kind of headache. The BP medicines are started, which may be good. The blood pressure always needs to be controlled, but headache might not be cured with that. And then in some kind of a tension type of headache, there's always spasm around the neck muscle. So thinking it to be some kind of spasm in the neck or spondylitis, the person would further go to an orthopedic and then eventually land up to either a neurologist or a neurosurgeon. So this is a long journey when it comes to headache. Hopefully, if it's treated before or if it's identified earlier, it's always better so that we can come to the right diagnosis. So now, who needs diagnostic imaging? Why do you need any kind of MRI or a CT scan when you have a headache? Oh yes, obviously, thanks to Dr. Google, now that we are lucky, we get patients with all kinds of scans, maybe a CT or an MRI, an advanced MR angio, an MR venogram, even if it's not needed. But Google has said so. Most of them will go ahead and get scans done. But do you actually need those scans? So who needs them? So if headache is associated with neurological signs and symptoms, that is, if headache is associated with some kind of a double vision, or there was loss of consciousness associated with an headache, patient had seizures or fits when he had a headache, or if there is imbalance while walking, like an ataxia. So if these neurological deficits are present along with an headache, you might need to get a scan done. If it's a progressively worsening headache, definitely a scan is required. If it's a new onset severe headache, or if headache is associated with multiple episodes of vomiting and fever. So it is this is a raised intracranial pressure kind of an headache when it's associated with projectile vomiting, that definitely warrants a further investigation with either a CT scan or an MRI scan. So investigations are needed for secondary headaches, and they are not much beneficial in primary headache. So now what are these secondary and primary headaches? So headache is a symptom. It is not a disorder as such. So a primary headache is one in which the disorder is the headache itself. And a secondary headache is one in which the headache is due to an underlying disorder. Okay, so primary headache constitutes 98% of the headaches. So you see here that 98% of times you might not need any investigation or any scan. So this is the commonest type. Out of that, in primary headache, tension type headache makes up 60 to 80% of primary headaches. And then migraine makes up 15% of it. And then the less common ones like cluster headaches. So these make up about 98% of the population having headache. So secondary headache is one when there is an underlying disorder, and then they can be multiple types that could be due to a space occupying lesion, basically like any tumors or infection in the brain or a bleed in the brain. So these are two types of headaches. And then, like I said, primary headache is the commonest one, which might not need scan or any investigations. Right. So the main thing, the single most important thing is patient history when it comes to a headache. Both at the side of the doctor as well as the patient, giving the correct history is very important, because most of the times primary headaches will be diagnosed correctly just based on the history. So when asking for a history, for example, recently I had a patient who came with me with severe headache. I asked the patient, does he have any other kinds of symptoms? So he said, no, I don't have any other symptoms, but suspecting it to be a tension type of headache, which is often associated with symptoms like anxiety and palpitations, I asked him, oh, do you have any anxiety palpitations? And then he instantly said, yes, I do. So I asked him, why didn't you tell me that? So he said, no, I will say that I'll go and tell that to my cardiologist. So it is not just the doctors who have become specialists now, even the patients have become specialists, but that's not how it should be. Give the right amount of history and then you can come to the correct diagnosis. For example, when you see migraine is a condition in which it is aggravated on rest, and it is relieved it's aggravated when the patient is on rest or when he's lying down. And so migraine is one which is aggravated when the patient is pacing up and down, and it's relieved when the patient is taking rest or lying down. Whereas the other one, which I mentioned, cluster headache, on the other side, it gets aggravated when the patient is lying down or is resting, whereas it's relieved while pacing up and down. And like I mentioned, a tension type of headache, it will have all other symptoms like anxiety, palpitations, and neck spasm. So most of these primary headaches can be diagnosed if the correct history is given. So that is one important thing which should be kept in mind, both from the side of the doctor as well as from the person who is having a headache. So I'll start discussing briefly on the common types of primary headaches. So the first one, which makes up the 60 to 80% of primary headaches, is a tension type of headache. So a tension type of headache is one which there will be a band of pressure around the head, and it is usually seen on both the sides of the head. It is bilateral, and it's a dull, aching, nagging type of pain which will be present throughout the day, or at least up to 4 to 5 hours. And it's associated with scalp, neck, and shoulder tenderness also. So risk factors for this are obviously anxiety, stress, poor sleep. Younger age is subjective. Anyone who's taking stress now can have this kind of headache. And treatment comes to the easier said than done things like relieving or taking less stress or having good amount of sleep, doing some kind of aerobic exercises, 30 minutes cardio or walking 30 minutes a day. So all these lifestyle modifications, which are easier said than done. So all of this will significantly reduce the amount of tension type of an headache. But if this is not followed, or it's even after this, the headache is persistent, then it can be treated with simple over-the-counter analgesics like paracetamol initially. And even if that does not work, if it is not episodic, that it's a chronic type of tension type of an headache where there are more than 15 episodes seen per month, then might have to be started on some kind of an antidepressants like amitriptyline or fluoxetine. But most of the times it is cured when the lifestyle changes are made, like taking less stress and good amount of sleep and exercise and a good diet. Okay. So the second commonest one is migraine. So whenever a patient has headache, the first thing they'll say is, okay, I have a migraine. But is it actually a migraine? Because the treatment is different for different types of headaches. So migraine makes up about 15% of the population. It is a moderate to severe intensity of pain, and it's a throbbing or a pulsating type of a pain. So it is mostly unilateral, which is a characteristic feature that it commonly involves only one side of the head. Although in some situations it might be bilateral, but most of the times, maybe more than 90% of the times, it is only involving one side of the head. And 1/3 of these patients always suffer from an aura. So now what is an aura? An aura is a warning sign which comes before this acute onset of an headache. So most of the times it is a visual aura, which is like a scintillating scotoma. Basically means that there is that area of where the patient cannot see, and there'll be surrounding that, there will be a bright or glittering lines around that. So this is the commonest aura which is there, a visual aura before the onset of an headache. And this commonly comes about an hour before the onset of headache or about 30 minutes, but mostly it will be not before, does not extend for more than an hour before an headache. Other than that, visual aura, there can also be sensory auras where there can be numbness of the limbs, like of the hand or the leg, or a motor weakness, that is any muscle weakness of the limbs. These can come before the onset of headache. So basically, it's a warning sign before the onset of an acute headache. So again, these can be episodic or chronic. And the most important in these, again, is to have a headache diary, because it is important to know which factors are triggering this, because most of the migraines have some kind of a triggering factor. It can either be bright light, uh, some kind of a sound, or it can be stress, less sleep, or some kind of dietary triggers like maybe cheese or wine or chocolate. So they have a lot of triggering factors, and it's very important to know what is the triggering factor and which triggering factor led to a headache. So very important to again keep a note of these by making a headache diary, which is again not followed commonly. Recently, I asked one of my patients who had a headache. So did you note it down? When did you have a headache? So this was an elderly woman. So she looked at her husband. So I asked her, do you have headache or does your husband have an headache? So husband smiled and said, when she has an headache, I invariably have one. But that is not the way to go. So he said, I will tell you when she had an headache and what were the precipitating factors. But that is not the way to go. The patient should write it in the notebook, and it so that we know which are the triggering factors and treat accordingly, because these conditions are not just treated with medicines. We need to know what are the triggering factors, and those triggering factors need to be controlled. So acute onset of headache, again, paracetamol or over-the-counter medicines, again, non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac can be given, or triptans is another group of medicines which is started. But if again these are chronic, that it is happening more than 8 episodes a month, not getting subsided with general over-the-counter medicines, then some kind of preventive therapy might have to be started. For example, propanol, which is given in patients with cardiovascular condition. These are antihypertensives, or antidepressants might have to be started, or stronger anti-seizure medications like gabapentin or valproate. So depending on the condition, but like I said, most important is controlling the triggers in this case. And once the triggers are controlled, then this condition, along with that acute onset headache, can be controlled with a basic amount of over-the-counter medicines. So cluster headaches is not a very common kind of headache. It is seen in about 0.1% of the population, but the pain is severe and significant. It is excruciating suicide headache. It is usually seen just behind the eye, lasts for about 4 hours, and it is called cluster because it keeps appearing in bouts. And then maybe it will keep on appearing multiple episodes during the day, and then there might be a period of remission for about 3 months, and then again after 3 months it might start. So this is severe headache. It is precipitated by alcohol and more commonly seen in men and in smokers. And treatment is in this, because the pain is excruciating initially, it has to be 100% oxygen is given. If it's available at home, then at home it should be given immediately 100% oxygen. This will reduce the amount of headache significantly. And then other medicines like triptans are started, and maybe other over-counter medicines like paracetamol and ibuprofen, etc. So now that was a brief on primary headaches. Now coming to secondary headaches. So secondary headache, like I mentioned, it is due to some kind of an underlying disorder. It can be anything. It can be because of trauma to the head, which causes some kind of bleed in the brain, or it can be because of other vascular causes like a stroke or an aneurysm or a venous thrombosis, or maybe due to some kind of bleeding inside or an hematoma inside the brain. There are multiple causes for this, but there is an underlying cause. So, like I said, it makes up about 2% of the population. So, in this case, when do you need to be worried that it might be a secondary kind of an headache? If you are having a headache, when should you think about it? Like, okay, could this be something else, or could there be an underlying cause? So it could be when there are other systemic symptoms, when headache is basically associated with some systemic symptoms like a fever or significant amount of weight loss, or if there is already some cancer or a tumor elsewhere in the body, or in a case of immunocompromised states, for example, when the body's immunity is low in conditions like HIV, or when there is a transplant which has taken place. So in these conditions, maybe you need to worry that there is something which has either metastasized to the brain or something which is primarily growing in the brain, or other neurological symptoms when it is associated with headaches like impaired consciousness, impaired alertness, some deficits like weakness of the upper of either an upper limb or a lower limb, or when headache is associated with seizures or fits. If the onset is severe, like already mentioned, if it's a thunderclap kind of headache, which is a sudden severe type of headache, or if headache is associated with some kind of a trauma. So if there was any injury to the head, which raise a suspicion of any kind of bleeding in the head or near the brain, or if it is precipitated by factors like coughing, sneezing, or exertion, which increases the intracranial pressure, or if it's a progressively worsening headache. So all these conditions, if you have an headache which is associated with any of these, then you might have to think, okay, is there something else? And do I need to get investigated for that? So these are the red flag signs. Okay, so the commonest one now is someone putting up headache on Google, and most of the people coming to us saying, okay, I put headache on Google and it shows that I have a brain tumor. So I have come with these scans. So no, so it does not show that you do not need to always get investigated for that. But coming to space occupying lesions, so what are space occupying lesions? So as shown here, these are any kind of lesions which grow in or around the brain or in the protective layers of the brain, and it can occur anywhere in the brain. So it's divided into multiple parts of the brain. It can occur in any part of the brain. And these lesions they can be of various types. They can either be benign, that is, they are locally growing there, or they can be malignant, that is, they are spreading, or it may not be a tumor at all. It can be some infection or an abscess, or they can be cysts. So it can be anything. Those lesions can, so there are different diagnoses for lesions, which is further evaluated by after doing some kind of a scan, which is relevant according to that. So basically, when there is any lesion which is growing inside the brain or around it, the skull being a rigid box around it, the brain or the layers around the brain, they do not get space. There is swelling because of the growing lesion. So they do not get space to move around or get around that because of the skull being a rigid box. So it causes stretching of the protective layers of the brain, which I mentioned previously is the pain sensitive structure and not the brain per se. So because of stretching of the surrounding layers of the brain, there will be some kind of headache which is always present with such lesions. Okay, so what is the classic type of an headache that we see in this? It is a headache which will normally present early in the morning on getting up, and it is associated with nausea or vomiting, and it improves in intensity throughout the course of the day. And this kind of an headache is commonly aggravated when lying down or bending over, and by Valsalva-like maneuvers, which means that maneuvers which increase the intracranial pressure, like coughing, straining, or lifting heavy weights. And the most important is this is rarely a sudden onset of pain. This will be a moderate intensity pain, which is present for quite some time and is gradually progressive in nature. And the headache is usually present on both sides of the head, sometimes based on particular type of lesion. If it's there localized to one side of the head, it could be present on one side as well. So now coming to treatment of these kind of lesions. So obviously having a lesion in the brain and maybe the fact that it needs surgery is always going to be scary. But now sometimes these lesions might not even need surgery. If it's a small lesion not causing anything, then it would just need symptomatic management with a few medicines, and with wait and watch and follow-up scans might be needed. But sometimes this might need surgery as well. So even though it's scary, now is the time and age of minimal invasive surgery. It would not require, like previously, like opening a major part of the skull and going in and removing a part of the tumor. But now, as I mentioned, it's a time and age of minimal invasive surgery, by which it significantly reduces the morbidity in the post-operative period, and also helps significantly in the post-op recovery, and the time spent in the hospital after the surgery is significantly reduced. So now, because of this, we have various gadgets which are used during surgery, a lot of technology like this one, in which it is a brain navigation, which is like a GPS for neurosurgeons, which will help us guide us to a tumor through a very small opening in the skull, so that we do not have to take big incisions, which again will significantly reduce the post-operative recovery time. And otherwise, also going through minimal invasive techniques like operating and reaching through to the base of the skull through the nose with the help of an endoscope. So taking also, this is most of them can be treated again through just a small opening in the skull and by passing through a small endoscope as well inside. So now, like I said, it's a time of minimal invasive surgery, and most of these lesions can be cured with minimal invasive surgery, which means that the patient is ready to go home by the 4th or the 5th day after a major brain surgery. So other option other than this is also radiosurgery, in which small lesions in the brain can be given radiation itself. It's a daycare procedure. Small lesions, commonly less than 2 to 2.5 centimeters in size, can be given radiation itself, which will cause these tumors to melt in a way. And again, it's a daycare procedure. So there are multiple options for this. And nowadays, it is the recovery is significantly less. The time which is required for this is significantly less, even after major surgeries, because of all the technology that we have nowadays. Okay, so now coming to the other common type of secondary headache is all the vascular diseases like aneurysms or a stroke or venous sinus thrombosis. So what is an aneurysm? A brain aneurysm is a weak area in the wall of the blood vessel, which causes the vessel to bulge out. Now, this bulged out vessel or the weakening in the vessel wall can then rupture, and it can cause bleeding in the brain. Okay, so this bleeding is a thunderclap type of an headache, so which is sudden onset severe headache. And it's commonly described by the person as the worst headache of his life. So it is the location may be generalized in this, will be present on both sides of the head, but commonly along with the headache, because there is some kind of bleeding in the brain, there will be other features like drowsiness or impaired consciousness or maybe seizures or fits. But commonly this headache is severe and it is not controlled by over-the-counter medications, and it definitely needs further evaluation and treatment. So what are the treatment options in this? So investigation is commonly in the form of, initially, this has to be investigated with a CT angiography. So a CT angiography it's a non-invasive technique which will specifically study the blood vessels in the brain. And then it is followed by a digital subtraction angiography, which is an invasive angiography with a small puncture through the artery in the groin. And then blood vessels of the brain are studied after giving a contrast through the artery there. So like I said, this definitely needs some kind of a treatment, because the chances of it rupturing again is high. And if there is a second rupture, then the bleeding is significant and can be life-threatening as well. So the treatment, so once this aneurysm has ruptured, it causes a clot in the brain, and it produces a temporary tamponade on the aneurysm itself, which leads to the bleeding to stop for the moment. But again, if sometimes the BP, blood pressure goes above, or some other factors can cause it to again, the aneurysm to rupture again, which can be life-threatening. So the treatment for this is to pack the aneurysm and or either to clip the aneurysm so that there is no blood flowing into the aneurysm as such, and then the chances of re-rupture are less. So it can be done by two ways. It can either be done by an open surgery and by placing a clip across it, or it can be done by endovascular or minimal invasive techniques, again through a small puncture in the artery in the groin, like we did an angiography, go ahead and pass a few catheters in the small arteries in the brain and pack it with coils, or maybe pass a stent across it. But definitely it needs some kind of a treatment and cannot be left alone if it is ruptured previously. So just to give an idea of how this is treated, this is a patient which was managed under my care recently. So they will come with came with complaints of severe headache and altered impaired consciousness. A CT scan is done initially, which shows some bleed, and then it shows on, like I mentioned, a CT angiography is done, which shows some ballooning of the blood vessel here. And following that, we do a digital subtraction angiography, which is a minimal invasive one, but this shows only the blood vessels of the brain, which here again shows us that there is a ballooning of the blood vessel. So we go ahead through the groin, we pass small microcatheter through it, and we pack it with coils. And this is a completely packed aneurysm. So the chances of it re-rupturing is not there. So there's a pre-op where we see the bulging, and there's a post-op, and all of it is done through a minimal invasive approach, just through a small puncture in the artery, again, which significantly helps in post-op recovery, and patients can go home again after maybe third or fourth day, because the post-op recovery is very less, because it's all done through a small puncture in the groin, passing very small, minute catheters inside the arteries in the brain. So these aneurysms can either be big or small. So this is, the previous one was a smaller one. This is the bigger one, again treated similarly by passing coils inside that through small catheters. Or again, like I mentioned, a stent can be passed through it, which will divert the blood beyond the aneurysm. So if the aneurysm is here, we place a stent inside the blood vessel, and it diverts the blood beyond that, so that there's no blood entering that part of the aneurysm, and there is no chance of re-rupture of the aneurysm. So all of these, again, like I said, it's the age of minimal invasive surgery. All of these have now been treated with minimal invasive techniques. So the second thing in vascular disorders which causes headache is a venous sinus thrombosis. So like I mentioned, these are the big veins in the brain which take the blood back from the brain back to the heart. So sometimes these veins can get blocked. So if these veins get blocked with some kind of a blood clot, then the blood which is going through it gets diverted into the small veins around in the brain, and they can't handle that pressure, and those veins rupture and cause bleeding in the brain. So that is the physiology behind this venous sinus thrombosis. But the most common symptom for them is again a headache. Okay, this is it's present throughout the head, again on both sides of the head, and it's usually associated with other kinds of blurring of vision, impaired consciousness, or seizures. Like all other kinds of secondary headache will sometimes have some other features also along with that. So this occurs when patient has some kind of blood disorders leading to excessive clotting. Normally there is clotting somewhere else. Like there's DVT, deep venous thrombosis in the leg, conditions like that, which already someone is predisposed to having some clotting factors, then it can be seen. Or in case of dehydration, again, there can be some amount of thrombosis in the veins. Cancers can cause this, and any infection of the inner ear, or the mastoid bone, which is seen around the ear. All these infections, because the veins are in close proximity to this, can again cause these thrombosis. So again, it is investigated with initially with a CT scan, and then with a specific kind of an MR scan, which studies the veins around it. Like we can see here, one of the veins around it are blocked. One side we can see good flow in the veins, but the other side is blocked. So that is a specific non-invasive kind of an MR venogram, which will give us a better idea of this. And these are managed medically by starting on blood thinners or on anticoagulation. And we try and open the path for the blood to flow through these veins by starting these blood thinners and increasing the hydration. And symptomatic treatment, if there is any bleeding or infection, then or seizures, then accordingly medicines are started. And if it's not controlled with with medical management, again, like I mentioned, there is this endovascular treatment for this, where we can go inside and we can, through a puncture, again, in the groin through a vein and go inside and take out these the blood clots and open the path. Like we see here, the one of the veins is blocked, but then we can go in through small catheters again and make way for the blood to flow through these venous sinuses. So again, this minimal invasive approach is also available for these vascular disorders. Okay, now coming to a very important topic of a stroke. I have specifically added it here because it is very time sensitive and awareness is very important for this condition. So if you are aware of these symptoms, so it may or may not present with an headache. It might sometimes present with weakness of of either the upper limb or the lower limb. But awareness of symptoms is very important, which can help us to get someone in need to the hospital and treat the stroke in time, because it is extremely time sensitive. So there are two types of strokes. It can either be ischemic stroke, where one of the blood vessels in the brain gets blocked either by a clot or some kind of a plaque, which goes up either through the heart or vessels in the neck. Or second, it can be a hemorrhagic one where there is bleeding in the brain. So the stroke, obviously, it can be it's a modifiable thing which doctors can modify if they can control hypertension, diabetes, hypercholesteremia. Then this can reduce the chances of having a stroke. And patients, obviously, if by reducing smoking, alcohol, controlling diet, again, lifestyle modification like exercise. So this can further reduce the chances of having a stroke. So to be aware is to know this. The B fast is very important. So to identify if there is, so B is for balance, if there is any loss of balance, headache, dizziness. Eyes is blurred vision. F is, and if there is any drooping of the face to one side. A is arms, where there is any weakness of either the arm or the leg. S is speech, if there is any speech difficulty or difficulty in talking, slurring of speech. Then T is time to call an ambulance immediately, because it is time sensitive, and if someone reaches within 6 to 8 hours, then it can completely be reversed by minimal invasive endovascular techniques. So it is very important to understand that anyone has these symptoms, it is important to reach the hospital within 6 to 8 hours so that appropriate treatment can be given and this can be reversed. For example, in this case, in which we can see that there is no flow distally into the blood vessel, and this patient came to us within 6 hours, and then we could establish the flow distally by just passing catheters and removing these clots which are present in the blood vessel through a very small retriever system or minor catheters which are present there. So this is a brief on the vascular disorders. Now coming to post-traumatic headaches. So it can be because of a small injury. This is occurring commonly after injury to the head or the neck, and it commonly begins about 1 day or maybe after 1 week after injury, and it is commonly seen on both sides of the head, and it's constant one. So if following trauma, if there are no danger signs like loss of consciousness or seizures, or maybe any weakness of the limbs, then this can be managed with over-the-counter medicines and usually subsides in about 4 to 5 days following a small or a minor injury to the head. However, very important to know is this condition known as a chronic subdural hematoma, which is commonly seen in elderly patients who are taking some kind of blood thinners like ecosprin or warfarin, like anticoagulants. So this is a commonly seen neurosurgical condition which occurs following a head trauma, which is usually a trivial trauma, which goes unnoticeable, like just banging the head to the side of the door, and usually goes unnoticed. But what happens is with patients who are already taking blood thinners, this thing goes on slowly. Their blood keeps on accumulating there over a period of time and forms clots around the brain, and which can further lead to a kind of headache, which again goes on gradually progressive in nature. Is associated with cognitive dysfunction, or maybe a weakness or in one of the limbs or while walking, which is why it is known to be like a reversible cause of dementia or Parkinson's, because maybe people will think of it to be okay, because the headache went unnoticed and there may be some defects in cognition, or walking might think of it to be a kind of a dementia or Parkinson's, but no, there might actually be a bleeding in the brain which can be easily treated, and it is a reversible cause. So treatment needs a plain CT scan, which will show us that there is bleeding in the brain, and sometimes might be treated with, maybe if the pressure in the brain is not high, then it can be treated with simple over-the-counter medicines. Or most of the times, someone will come to us only after the pressure has reached a significant amount of time in the brain, or the intracranial pressure is high, because that is a time when they start developing these kind of symptoms of either weakness or cognitive defect. So it will need a surgery, which is again a minimal invasive one, which is made by just placing two maybe holes in the skull, and the clot is evacuated, which is normally found not in the brain but around the brain. And so it can be easily removed by just placing two burrows. And again, the recovery is very good. Prognosis is very good in these conditions, and uh, can easily be discharged maybe on the fourth or the fifth day after that. And it's a reversible cause weakness. And maybe if there is weakness in one of the limbs, then that is also is reversible after this kind of a surgery. Or again, there is minimal invasive approach for this, in which the blood vessel, which is like we see here, there is a blood vessel which is supplying the clot, that can be blocked by again going through a puncture in the groin, like we discussed previously, by going there and blocking the blood vessel so that the clot further does not increase. But this is only done in case of recurrent bleed after doing this burrhole surgery, which is also a minor kind of a surgery. Okay, so just coming to the last few causes of a secondary headache. So meningitis is commonly meningitis, like I mentioned, the meninges is the protective layer around the brain, and meningitis is an infection or inflammation of these layers of the brain. So it can be either due to a bacterial or a viral or a fungal cause, and this usually presents with a severe type of headache, which is an excruciating pain. Again, presents with a thunderclap type of an headache, which is sudden and severe onset of headache. So this is usually treated with, again, conservatively based on what is the cause of it. Either a bacterial, viral, or fungal will need treatment or antibiotics according to that. And rarely maybe surgery might be needed with placement of a small shunt in the brain to divert the maybe the CSF or the fluid which is present in the brain. So another thing is a sinus disease. Okay, a sinus disease is not a common cause of headache. So acute sinusitis, so many of them will feel like, oh, my sinuses are blocked and I have a headache, but sometimes that might just be a migraine. So acute sinusitis is associated with fever and a yellowish greenish discharge from the back of the nose or the throat. And sinusitis is often associated with nasal congestion or obstruction and a thick nasal discharge, which will give a feeling of fullness or pressure around the face, where the sinuses are seen commonly around this area of the maxillary sinuses or the frontal sinus maybe. So a facial pain or pressure or fullness without a discharge from the nose or cloudy or colored discharge back of the throat is less likely to be a sinus infection. And for this, it should not be treated with antibiotics, in case it might just be a migraine or a tension type of headache. And so there is no role of antibiotics in that case. So it can again be evaluated with a simple CT scan, where we can see that the sinuses are normally filled with air or pneumatized, which appear black, and in an infected case, there is some kind of collection in those sinuses. Okay, so the second last topic of this is on trigeminal neuralgias. So a trigeminal neuralgia is a condition which presents as a chronic pain disorder that involves sudden attack of severe facial pain. So these pain attacks typically last only a few seconds, but they may occur multiple times, several times during the day. And these attacks it's debilitating because these attacks are again and again triggered by just simple daily activities like washing the face or brushing the teeth or blowing the nose, eating, drinking, talking. So all these can trigger these kind of an attack. So treatment in this case is initially diagnosis is clinical because the symptoms will tell you that it is some kind of a trigeminal neuralgia. And why is it called trigeminal neuralgia? Because the pain is because of a trigeminal nerve which comes out of the brainstem and it supplies the side of the face. So because of irritation of that nerve, these symptoms are seen. So it is called as a trigeminal neuralgia. So initially conservative management is given with medicines to reduce this kind of symptoms. But if it's persistent, then it might need a surgical intervention in the form of doing a small opening in the skull and placing a Teflon, because it's not only that there is one of the arteries around this nerve which goes and starts pulsating on this nerve and causes irritation of the nerve, because of which these symptoms are seen, and it is present throughout the day. So surgery involves just separating this artery from the nerve and placing a Teflon patch between it so that the pulsation of the artery does not irritate the nerve further. So this is the surgery which is done. Other than that, there are other minimal invasive surgeries like passing a needle into that around the nerve under X-ray guidance and destroying the nerve fibers which are causing the pain. But again, that is temporary. Definitive treatment in this would be the surgical intervention by placing a Teflon patch. All right, so the last one here is of cause of secondary headache is a medication overuse headache, where it's also known as an analgesic rebound headache, where headache is persistent for about more than 15 days a month and for more than 4 hours a day for 3 months or more. Then it is classified as a medication overuse headache. And this is when a person is popping pills constantly, and it's commonly seen with opioid containing analgesics like tramadol or morphine or codeine, and with combination agents like aspirin or paracetamol and caffeine containing combinations. And it's less when only maybe triptans group of medicine or simple non-steroidal anti-inflammatory drugs like an ibuprofen or diclofenac is taken. But this, if it is persistent, again, this would need a visit to a specialist, because this further requires multiple stages of treatment by withdrawing those drugs, and along with that, having other lifestyle modifications like reducing the stress, relaxation exercises, stress management exercises, and again, treatment like headache diaries and mentioning which are the trigger factors for headache. But again, in this case, if it is diagnosed as an headache or a medication overuse headache, then simple medicines like maybe a paracetamol or ibuprofen can have to be stopped abruptly. But the more stronger ones, like the opioid ones, like morphine, etc., need a gradual withdrawal and then bridging them with some other kind of medicine so that the headache is cured and also there is no overuse of medication. So this definitely needs a visit to a specialist and would require some monitoring and modification of medicines. Okay, all right. Thank you very much. I hope by the end of this, I'm not the reason that someone has an headache at the end of my presentation. Thank you very much. I'm happy to answer any questions.
Thank you very much, Dr. Ishant, again, for a very detailed presentation. I think it was very detailed. It has almost all the information that somebody would like to have. So, as I mentioned in the past, this video is being recorded and it will be edited and put on our website, that is seniorstoday.in. It will be there on Monday evening, so you can watch it once again and take notes and consume once again all the information that was given so painstakingly by Dr. There is a question from Jayanta Das from Kottayam. He asks, I have been suffering from headaches every afternoon since the onset of summer. I was told it is migraine and asked to treat it SOS with Vasograin. No investigation was done, but the headache goes with this. Is there a permanent cure for migraine?
Yes. So like I mentioned, the most important thing in migraine is to identify what is the trigger factor which is causing that migraine. So it can be because of heat, it can be because of bright light, it can be because of a loud sound. So it is very important to identify what is the trigger factor for that. So medicines are again going to be temporary in this case. If there is some kind of an aura, like I mentioned, then you get a warning sign, then maybe you take the medicine at that point of time so that the onset of headache is less. But the most important is to know what is the trigger factor and avoid the trigger factors and continue symptomatic treatment. It is better to avoid preventive treatment where we start medicines for a longer time. But with medicines and trigger factor, if the duration of migraine and the severity of migraine has come down by less than 50%, then it is considered that the treatment is right. So you continue with that kind of treatment and avoid trigger factors.
Right, doctor. There's another question that has come in, and in fact, I would like to add to it as to if I do have a headache, what is the over-the-counter medicine that one can take even before I approach the doctor? Do I have aspirin? Do I have paracetamol? or something like an ibuprofen, what is it that you would recommend?
Okay. So the first medicine you should ideally take is a simple paracetamol. To initially start with it, we always try to start with low dose and less power of medicine. So a paracetamol is good enough to start with. If symptoms are not improving with that, then we go to maybe a non-steroidal anti-inflammatory drug like an ibuprofen or a diclofenac. And if it's not getting relieved by that, then you should come and visit a doctor after that. But avoid taking aspirin. Aspirin is also has a property of being a blood thinner. So maybe if along with giving a property of reducing the headache, there could also be this added risk of maybe if any kind of injury is to happen, then it can cause clot somewhere in any part of the body. So it's better to avoid aspirin, but definitely can start off with paracetamol and then go on to diclofenac or ibuprofen.
Doctor, we've crossed the 5:45 mark, so if it's okay, we've got quite a few questions already.
Okay.
So if you don't mind, we'll perhaps go on till 6. This is a question from Mr. Bhushan Saikar, who asks, can chronic headaches lead to seizures, or is the headache a premonition of seizures to happen?
Chronic headache per se won't lead to seizures. Seizures will occur when there is any lesion or some pathology which is irritating the brain parenchyma. So seizures will only occur when there is some kind of irritation of the brain parenchyma. So just maybe a tension type of headache which is chronic or a migraine headache which is chronic will not lead to seizures. There has to be some underlying pathology which is causing the seizure. So that has to be evaluated again.
Thanks. We have a question from Mr. Kamlesh Vajpayee, who's 70. He feels like falling sometimes with tightness in the head. He has been prescribed Sibulin 10 mg daily. Is that okay? No vomits. Before you answer this question, I must advise all our viewers here that this session is advisory in nature. So while you do ask questions on specific medicines, it's always best to have a clinical session with a doctor, and whichever city you may be in, please do that. Of course, you can also contact Dr. Rege and would be happy to do a teleconsult. Yeah, over to you. So I'll just repeat the question. This is from Mr. Kamlesh Vajpayee, who's 70, who feels like falling sometimes with tightness in the head. He has been prescribed Sibulin 10 mg daily. Is that okay? He asks. And he doesn't have any vomiting.
Okay, so if I get the question right, he has had multiple falls before and then hasn't had a headache. Okay, so I'll just okay. So if he's like falling sometime, then it's not going to be because of the migraine. There has to be some other pathology which is leading to this imbalance when he is having while walking. But other than that, for the tightness in his head, maybe it has been diagnosed as a migraine and he's been advised Sibulin for that. It's okay to take that. There is no problem with continuing with that medicine. But if there is some kind of a movement disorder which is associated with the headache, it may not be because of the headache. There could be something else which is leading to that movement disorder at this age, and maybe at an age of 70. So that has to be investigated as well. But there is no problem with continuing the medicine for migraine.
Right. Thank you. We have a question from Mr. Lakshmi Narayan, who is 69. He says he normally gets a headache if he walks in the sun. It helps if he walks. Will it help if he walks with a cap?
Yeah, this again falls in the category of a migraine. If he knows that is a trigger factor, every time he's going out in this bright light, it's giving him a headache. So this will definitely, if I feel that you should try and avoid doing that, but if it's absolutely necessary, then maybe a trial with a cap may be given, but it might not. If it's recurrent episodes are there, it might not help. So either it's best to always try and avoid these triggers and maybe go for a walk in the evening also.
Right. Thank you. We have a question from Mr. Mayank Chakrabarti from Calcutta. His question is, how do we treat headaches related to anxiety, which is refractory to anti-anxiety drugs?
Yeah, so that will require a lot of lifestyle modifications and maybe a visit to a psychiatrist again. And medications will have to be tailored according to that. So maybe not just starting, like I mentioned, we need to start some kind of antidepressant. We directly do not start antidepressants. That when I mentioned in one of the slides that only if it gets chronic is when we would start some kind of an antidepressant. So that again needs further follow-ups and may be requiring treatment for anxiety as such, which is, and maybe stress disorders. Lifestyle modifications are very important. Getting up, me having a proper sleep wake cycle, sleeping on time, doing some aerobic exercises daily, 30 minutes of walk daily, eating well, avoiding alcohol and smoking. And other than that, medicines are altered accordingly. There are a group of medicines, antidepressants, which can be altered accordingly so that it benefits in the headache as well, and which reduces the stress or the tension which the person is taking, which is leading to this kind of an headache.
Right. We have two more questions, Dr. Where one is from Shamla Ravi. Question is, what is the chance of recurrence in case of meningioma after surgery and CyberKnife radiation?
It depends on how much of the tumor was removed. Meningioma is a benign tumor of the brain, so it is a locally growing tumor which causes pressure effect on the surrounding structures in the brain. And this tumor commonly arises from the protective layers of the brain. So it is not from the brain as such, but from the protective layer surrounding the brain, which goes and causes pressure on the brain surrounding it. So it depends on how much of the tumor was initially removed. So commonly in case of meningioma, we would ideally go ahead and remove the tumor completely. When it is a meningioma, again, it depends on the location of the tumor. So if it's a skull-based meningioma, it's a different management protocol. If it's a convexity one, which is arising maybe over the skull, any part of the skull, then that is removed in toto or completely. So most of the times we will take these out completely, or sometimes when there is a residual of less than 2.5%, 2.5 centimeters or 3 centimeters, then radiation, that is CyberKnife, is given after that. And the tumor usually will melt in a period of about 2 to 2.5 years. Chances of recurrence after meningiomas are quite less. Maybe I may not know the exact number, but it is less than 5% is what I have seen in my practice, is these will not recur if removed adequately and completely.
Right, thank you. We have a question from a senior citizen viewer here who has. This is a question not for a senior citizen, but since she's a senior, I'm asking her. She says, "A salute to you and your fraternity. This was an eye-opening presentation. My daughter tends to get a headache just before the onset of her periods. Sometimes after it is over as well. Why does this happen, and is there a way to avoid it?"
So this is another, it comes under a category of known as a menstrual migraine. So this is another subtype of migraine, which is seen when, like she mentioned, like during or just before, is like a warning sign again. So in this case, there is no option, like the treatment for this would be to start medicines before the onset, now that we know that there is a triggering factor, that is the menses, which is, and because she knows that this is particularly occurring maybe on the first day or the second day or the third day. So the time which is it is maximum, we know that is a warning sign. So treatment for this migraine has to be started before that. So maybe if it's on the fourth day, the third day, the medicines have to be started. And then for the next 3 or 4 days, the medicines have to be continued. So these kinds of headaches will stop commonly after menopause. So menstrual migraine is such a condition where these headaches have to be tolerated during that time, and usually will stop after someone attains menopause. So medicines have to be altered according to that period of time and have to be continued for that period of 4 to 5 days.
Thank you very much, Doctor. You mentioned about aerobics and walk for 30 minutes. Now we have Mr. K.V. Lakshmanayan once again mentioning that he finds that one-sided breathing relieves pain in the body, including the headache. So
one-sided? Sorry, I didn't get the
one-sided breathing. One-sided breathing.
Okay.
Is that something that you would, or is there any exercise that you would recommend that one should do?
Yeah, definitely. Breathing exercises will significantly help with migraine because they again improve the oxygen concentration which is going to the brain, and definitely improve with migraine. So all these kinds of breathing exercises and cardiovascular exercises, like maybe even simple exercise like walking for 30 minutes a day, or maybe other things which activate our happy hormones, whatever, going on maybe a trek or climbing a hill. All of these significantly help with reducing the migraine pain. So yeah, definitely breathing exercises do help.
Right. And Doctor, there's one last question. I'm sorry to take this. What about Ayurvedic and homeopathic therapies for headaches? Is that something that you would advise?
I may not be the right person to answer that. So I don't have much information on Ayurvedic and homeopathic treatments. So I don't know. I mean, if I say something, it might just misguide someone. So I can't comment on that.
Great. Thank you very much, Dr. Ishant Rege, for this very detailed presentation. Thank you very much.
Thank
And
you
to
very
all
much.
over here, thank you for joining. We will be there once again next Saturday at 5 p.m. for another session of Health Live at Seniors Today. The last question that we asked Dr. Rege, we're actually going to be speaking with a leading Ayurvedic doctor next time.
Yeah.
And we're going to be discussing these issues about Ayurveda. Is it really based on clinical research or not? There are quite a few doctors these days who are working in hospitals, or perhaps as assistants with a BAMS degree. Is it valid? What is it? So we're going to be raising all these questions next Saturday at 5 p.m. Meanwhile, Dr. Ishant Rege, thank you for this.
Thank you for having me.
Those of you here, you know that this is being produced by Seniors Today, the magazine, the website. We have an evergreen club where we have sessions here every day, twice a day. We have Mr. Lakshminarayan, who asked a question just now. He conducts a session. Ms. Anita De Rakshit, who's also here, she conducts a session every week. And I'm sure there are others as well whom I'm not able to notice here. But download the app, which is on Android as well as on iOS, and enjoy yourself, enrich yourself, have fun. Our Seniors Have Talent, the 15th season is starting soon, starting next month. So if you have any seniors above the age of 60 who would like to participate in it, please send us their contacts or ask them to connect with us at events at Seniors Today, and we will be glad to help them and engage them. We've had 15 seasons. We've had over 1,000 odd people who have participated in this. They have fun. They've been doing that for the last 3 years. I must mention here that those of you who would like to register pre-register for our Health Live sessions can do that by filling in a small form, and we will ensure that you don't miss a session. At least you'll get intimated by that. And that's about it. Too many plugs to do, but I guess these announcements need to be. Thank you very much once again.